Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today, we have the pleasure of being joined by Dr. Philip Hamann, consultant rheumatologist at North Bristol NHS National Health Service Trust and clinical lecturer in rheumatology at the University of Bristol. As the brain behind the Living With Rheumatoid Arthritis smartphone app, Phil is passionate about using AI to monitor and manage individuals with rheumatoid arthritis remotely, and we're going to get into that. When he's not practicing medicine or innovating, he enjoys cycling and playing the violin. And, well, let's get into the questions because he's done something else that is certainly on my bucket list. So it's my pleasure to welcome to the EMJ podcast, Dr. Philip Hamann.
Thank you for having me.
So it's a pleasure. So I've got to get into it first. I could frame this that you've expertly presented your research in some unique ways, including a TEDx talk, which I watched, and even stand-up comedy at the Canteen Comedy Club in Bristol on myositis and RNA. And additionally, and you're my hero, you've performed at the Edinburgh Fringe, which is something I really want to do. I do a comedy podcast on medicine, a humorous podcast on medicine. So I'd love to do that. Can you tell us more about those experiences and using humor to communicate complex scientific issues?
Yeah, so I mean, the stand-up work I did at the canteen was there was an opportunity to present for local scientists and researchers to present their work to paying members of the public at a comedy venue in Bristol. And I have always enjoyed being involved in theatre and communicating, and saw this as an opportunity and thought, I'm going to give this a go. What's the worst that can happen? And it was a great experience. And they had, obviously they realised that not necessarily all researchers and scientists are natural stand-up comedians. So there was a stand-up comedian and MC that gave us a bit of training. We got an opportunity to practice a little bit before the event. And then we went live, and it was terrifying, but really good fun. It was doubly terrifying because people were actually paying to come and see us. So it wasn't even sort of a voluntary sort of sympathy vote that people were turning up to see us. But it was really enjoyable, and also really highlights the importance of really simplifying your message when you're trying to communicate complex science to the general public. I would highly recommend it. I've done a bit of improv locally. There's an improv club that I did on a Monday until my daughter was born, and then it was a bit difficult to fit in improv on a weekly basis in the evening. So that's fallen a little bit by the wayside, but something I want to get back into. And then obviously Edinburgh Fringe, and I did some theatre at university, a few plays in Nottingham.
You make a very interesting point, Phil, about simplifying messages. I would go further and say we should simplify messages when talking to one another, because I trained at some of my training at the Hammersmith, and the chap who was the professor there at the time, Les Blumgart, ran the weekly rounds where you would present, and also at Liverpool University there was a guy named Black Jack Robinson. God, he was terrifying, and he taught us how to present. And he said, if you're presenting on a topic, you doubtless know more about that topic than anyone in the room. So, don't try and blind them with science. Simplify the message. Is that a fair comment, or is science now so complicated we have to make it?
No, I mean, I think it's a trap often we all fall into, is particularly in our areas of expertise where you spend your time thinking about it and approaching it from different angles, and you've got such depth of knowledge in that field that you assume that peers will have that same depth. And it can be really tricky to take a few steps back and pitch that real balance between you don't want to patronize people, but equally you don't want to lose them. And I think you're more likely to lose people than patronize people. And if when you're presenting, it's too simple for people will ask questions. And but if it's too complex, you'll have often the silence at the end of a talk. I'm always a little bit nervous when there's no questions, and it's either because you've just presented just after lunch and everyone's definitely nodding off, or you've completely lost them. So questions are good, and I think that's where you pitched it about right.
Yeah. Well, I love the idea about getting tuition from someone who is, uh, in this case, a stand-up comic. I think it's brilliant, and I think a lot of people in medicine could do with learning how to present and how to make slides and all those issues. Because it doesn't matter how brilliant your research is if you can't tell people about it in a manner they'll digest right over
Yeah.
their head.
And,
So during,
sorry, go
I'm
ahead.
sorry, go ahead.
I was just
No, no.
saying, I mean, what's really interesting is how different a perspective people can have of what you think is a really straightforward concept, and that you can think it is really that there's only one way of interpreting this, and someone who has no scientific background will look at it from the completely the opposite end of the spectrum.
Right. So during your PhD in 2015, you conceptualized and developed the award-winning smartphone app that I mentioned, Living with Rheumatoid Arthritis, for remote patient monitoring. And that facilitated a rapid shift to remote consultations, obviously at the start of the pandemic, which changed the way everyone practiced medicine, and has now been adopted within the NHS. And I have to take my hat off to you. To get anything adopted within the NHS is, my goodness, that's like herding cats. What inspired you to create the platform, and how's it changed the way that rheumatology care is delivered in your practice and, more importantly, around the country and maybe even globally?
So the original idea came back in, it probably was about 2014, 2015. We had the hospital I was working at the time, we had another, as is I think quite common in many departments, a backlog of appointments that we needed to see people, not enough slots in which to see them. And the method of managing that at the time was going through the paper case notes of the patient, and a consultant going through and essentially assessing the likely necessity of an appointment, the urgency of the appointment. So triaging this backlog of appointments based on their last clinic letter and not a huge deal more, because that was the information that was available. And it struck me as not a very efficient use of clinician time to be doing this, triaging on out-of-date information. And I thought, I bet the patients could tell us if they need us to see them right now. We just need a way of communicating the patient feelings over to the hospital. Now, 10 years ago, sort of apps were sort of reasonably mainstream, but becoming more of a thing, particularly in healthcare. And I thought, this could be an opportunity to use a very validated patient-reported outcome measures that we've had for decades, ask patients to communicate that through to us via an app, and then we would know what's going on with them. And this idea had been sort of fermenting in my mind for a little while. And I happened to see one day when I was walking in at the University of Bath, Apps Crunch competition, which was the university had teamed up with their entrepreneurship department and said, enter your idea for an app. Any app will do. Just submit in. You don't have to be a coder. So I entered the concept into this competition, and to cut a long story short, won the competition. And as part of the prize, there were two sort of aspects to it. Number one, they linked me up to a local company who developed smartphone apps, who I've been working with, called Living With. And the other part of it was very exciting. It was an all expenses paid trip to San Francisco and New York to visit their alumni. So we had the opportunity of visiting Facebook and Instagram and Google, and seeing some of the venture capitalist firms out there, and having the opportunity to pitch our ideas to them. So get an experience of what it's like to pitch at that sort of level. And then also to Deloitte and other sort of significant industrial partners that they had. So it was a great opportunity in terms of communicating ideas across to non-medics again. And then, as well as that, the great catalyst of being put in touch with this company that then agreed to work with me to develop the app. And again, communication, it comes back to communication as well, communicating to software developers and entrepreneurs your idea to try and get this off the ground. And indeed we did. We came up with a minimal viable product. And then I happened to move after I finished my PhD from Bath over to Bristol, and mentioned this idea to one of the consultants there, and they were very enthusiastic and broadly really open to innovating and taking this new idea under the wing. So this was about 2018, and we started, very sort of small scale numbers, getting patients enrolled and really just seeing how it worked. And I think this is one of the key learning points I say to anyone who's doing innovation is don't spend forever trying to plan a perfect solution. Just go get yourself to a minimal viable product that just about works and does what you want it to do, and try it in small numbers of people and iterate on those ideas. And it's much easier to fix problems and find the problems than spending years creating what you feel is a perfect solution only to be undone by something you would have found within the first weeks of deployment. So we had it slightly, up and running in about 2018 and 2019, gradually accumulating the number of patients. Then obviously in 2020, when the pandemic arrived, there was a massive uptick because it sort of really highlighted the benefit of being able to understand what people's experience of their arthritis was like without being there face to face. So it sort of really upticked from 2020 and onwards.
Fascinating. I mean, your comment about innovation I've been very privileged to be involved in a number of initiatives, and you're absolutely right. And if you look back at the business plan that you wrote at the inception of a concept, and then look at it 5 years later, it often bears no resemblance to what you thought you were going to be doing, because voice of the customer, if you will, voice of the end user is going to change, and there's no point building a better mousetrap hoping that they will come. I think it was Emerson who said that, but rather actually ascertain what people want and deliver that. But then there's the contrarian position, which I think Henry Ford first came up with, and I know that Steve Jobs concurred with, was that, if I asked people what they'd want, they'd have told me they wanted faster horses. And Jobs said it's pointless asking people what they want. They don't know what they want. I have to give them what I know they want. So how do you square that circle?
Well, I think in that regard, there is also a bit of an overlap between the two. Steve Jobs clearly had a vision and clearly saw a gap in the market and a version of events that he thought was enough to pursue a different way of doing things. And in that regard, yes, people can struggle to think about how you might do things differently from what we do now. And people's ideas might be, well, we're just going to do what we do now, but faster. That takes you to the faster horses concept. And I think sometimes you do have to say this is a different way of doing things, and you do have to tell people what they want, to paraphrase Steve Jobs. But they'll also tell you very quickly whether or not it's not going to work. And Steve Jobs was correct in his vision, in seeing where the gap was. What we don't ever hear is the many Steve Jobs that did that same thing and were told by the market or the other customers that it wasn't quite what they saw the future to be. So we hear the successes, and in that regard, obviously he was phenomenally successful. But I do think that sometimes when you're looking at a shift change in how to practice or do something, sometimes you'll find, in fact, in many cases, you'll find that people either just can't quite envisage that way of doing things. And you have to kind of keep pushing your message. And sometimes they will see it and they'll pick it up and they'll really run with it. And then you have that, that great success.
Yeah. Well, fantastic. So, I wonder how well it would have taken off had it not been for the pandemic. But I think we'd have got there eventually, because telemedicine is very clearly here to stay. And it's finding the right way to use it, not just force-fitting solutions. So your PhD used real-world data from 15,000 patient clinical records to examine how people with rheumatoid respond to high-cost drugs. So I don't think there's any doubt that elements of personalized medicine are here on the good side, right? And we've got biomarkers now allowing that, and artificial intelligence will help us find the right drugs for the right patients. That's all great. On the other hand, how do we pay for all of this? Because in case people hadn't noticed, things are not exactly rosy on that front.
Yeah, so I mean, in terms of the work I did for my PhD, it was working on a national database or registry that we have called the British Society for Rheumatology Biologics Register. And I was very privileged to work with Professor Kimi Heirich up at the University of Manchester, who was one of my supervisors, and locally in Bath, Professor Neil McHugh, and also John Pauling, one of my supervisors. And we worked together to try and understand who would do well in the long term with different medications and see if there were any differentiating features between them. The idea being that potentially we could try and work on profiling patients. And the work sort of identified some broad differences between different categories of patients. But it was using some really quite innovative methodology with one of my other supervisors, which was Professor Gavin Shaddock, who's a statistician. And we looked at trying to model future outcomes using sort of Bayesian techniques towards the end of my PhD. And this actually overlapped and dovetailed really well with where I saw potentially with remote reported outcome measures and what we could do with that data. One of the great challenges with registries is data collection, even at the most frequent, is often many months apart, particularly if it's going over a longer period of time. So the most frequent data collection points we had in the biologics register were 6 monthly. And obviously a lot happens in 6 months. So the idea of being able to capture more data between those points was something I thought would be certainly possible using remote reporting. And then using the sort of Bayesian statistical techniques, which is slightly different from sort of, if you like, more standard run-of-the-mill statistical techniques in that it uses variations on a hypothesis, so you can kind of predict things more easily. I'm trying to work on communication here, Jonathan, in Bayesian mathematics, but it's much more flexible and can work much more easily with real world data, and is a sort of a foundation on which some AI is built. And it's that sort of concept of being able to combine data from different data streams that you can do in Bayesian methodologies that I found really interesting and thought is an iteration that you can work on with the remote reported outcome measures. And you mentioned about cost. And so I think there's different costs that we're talking about here. There's obviously costs of medications and the cost of our biologics drugs, so the high cost drugs in rheumatology. We've been very fortunate, in fact, that market factors and a lot of our drugs have started to come off patent, and we're getting generic drugs into the market, and the costs have absolutely
The biosimilars.
Biosimilars, yes, yeah.
Yeah. Right.
So again, innovation is playing a key role there in driving down the cost there. And I think also if we still could do a lot of work on targeting those drugs and trying to find out who is the right person to have the drug first time. There is still a degree of trial and error in clinical practice. Starting with the most likely to work drug, and then iterating your way through if it doesn't work, and that is something hopefully over time we'll get better at. We're working on it, but it is something with time.
Interesting. So you recently published the results of a 12-month clinical pilot of the app in NHS rheumatology clinics in Bristol, your neck of the woods. What were the key findings? Then where do you take this kind of work next?
Well, we certainly found with that patients, are initially very enthusiastic with using new technologies, and it was really helpful to be able to have this initial 12-month period to look at and see how people sustained the use over time. But as you'd expect, there was a drop off, and we certainly saw that over that period of time, it dropped down to around about sort of 40 to 50% at the end of the 12-month period. Now, you might sort of feel a little bit sort of disheartened and think, well, we've lost lots of people using our app over that period of time. But what I've framed this in is this was a very much a real world scenario. So these people who were using the app were not being phoned up or chased by study managers to complete stuff or regularly being emailed to follow things up. This was an organic use of an app in the clinical environment. And so actually I find it quite useful to know that we do have a core of people who are interested in using it, and they do seem to use it. And then there's some people who will initially engage with it and then drop off. And so it opens up the next level of questions as to why do people keep using an app? Why do they not use an app? And or why are people engaging with digital technologies? And we've continued working on the data. So we've got another paper that's submitted at the moment, looking actually out to 4 years and seeing how things go over that time. And that sort of, if you like, the Kaplan-Meier curve kind of does continue to drop over time, but less steeply as you go. And I think what's really important here is that there's clearly some different groups of people who engage with technology, and it's not necessarily what you'd think. So if you started at this from the outset, you would probably think, well, young people are going to engage with digital technologies more, and older people might find it more difficult because it's a technology. And what we found is actually the opposite, that actually older people, when I say older people over the age of sort of 50, 60, engage and report more than younger people. Exactly why is difficult to know, because we haven't yet done that research. But you could certainly postulate different things. But it's interesting the how it flips. We've also found that the disease activity, so how active people's disease, doesn't seem to play a big role in whether or not they engage with it. So another thought you might have at the outset is that, well, people, if they're really having a bad time, they'll tell you about it and they'll fill in lots of outcome scores and tell you things are terrible. And then when it's good, you won't hear from them anymore. And that's certainly the case for, some patients. That certainly they do. But when you look at it in the main, there doesn't seem to be a strong relationship from the data that we're looking at it. It's very preliminary work, and we're looking at diving into that in a bit more depth with some qualitative research to try and explore who uses it and why they use it, not in the sort of quantitative sense, but really find out from our patient population what it is about these technologies that are either barriers or facilitators for them, because that's really key. If we're hoping that people are going to use these sorts of technologies long term, we need to know why.
Yeah. And where does it go from here, do you think?
Well, so one of the key things that we'll be looking at in some research that we're hoping to do towards the end of the year, beginning of next year, will be finding people who actually don't engage with the app. So we've got a database of people who have been invited to use the app and never downloaded it. And we would like to talk to them and say, what is it about this that makes you think it's not for you? Because ultimately, we all come from our own standpoints and our own experiences through life. And we all have blind spots as to, what we might not see as problems for us, maybe big problems for other people. And so by directly talking to those individuals, we hope to get a better understanding about exactly, what those barriers are. And I think we talked earlier a bit about the sort of importance of iterating on technology and not just waiting to build a huge perfect solution and then roll it out to everyone. This is part of that iteration. And I think, there are clear benefits from using digital technologies, that we can improve scale, efficiency, quality within the health service. It's not going to be for everyone, for every time, for every part of their disease. But we need to understand where those areas are. And the assumptions that you come at these technologies to start with are often not valid. As I've just said, you might think young people engage more. They don't seem to. You might think people engage more when things are bad. They don't seem to. So we need to talk to people and understand.
Yeah. Anytime, going into a research project with your eyes open and your I guess your heart open to what you might discover. It's interesting. I was smiling when you were talking about older people. I was involved in some work with telemedicine with a dear old friend, Yulan Wang, who's been a guest on this podcast, and with robotics. And we had a mobile holonomic robotic platform for doing telemedicine type stuff. And one of our first ideas was, could we use it to engage with old people, maybe in Alzheimer's settings and such like, and so the relatives could visit them remotely with this device. And a lot of people said, oh, yeah, no, it'll frighten them and they won't want to engage. Well, the older they were, the happier they were. And in my personal experience, Phil, it was my 90-something-year-old, I think she was 91 years old, when she was teaching me how to text and what all the LOLs and everything meant. She taught me. So who the heck knows, right? So you obviously you're passionate about real world data, real time data to ensure patients receive the right treatment at the right time. And I guess some of your work with this app is going to give you that access to that kind of data. Why is it particularly crucial for people with conditions like rheumatoid? And I guess a second part of the question would be, do you have any plans to take your platform and use it for people who are living with other long-term conditions, chronic conditions?
So yeah, so I mean, to answer the first part, why is it important for people with rheumatoid arthritis and inflammatory arthritis conditions in general, is at the moment, or broadly, our follow-up model for people with long-term conditions like rheumatoid arthritis is, as a consultant, I will see them in clinic, and then based on my experience of working with them to look after their long-term condition, we'll make a rough assessment of when we should probably next meet to review their medication or review how they're getting on. And it's a sort of educated guess scenario based on today and based on what's happened in the past. And you say, well, I think let's catch up in 6 months' time, say. Now, that is an educated guess. And what often happens is the patient may well come along to the next appointment in 6 months' time, and we talk about the arthritis and it's still fine. And they go home, and then a month later they have a flare. And so the appointment I had with them was, very pleasant. We had a chat, we caught up, but didn't actually make probably any meaningful change at that point to them. But the appointment would have been better suited a month later when the problem had arisen. So that's a not necessarily optimal use of NHS resource in terms of my time, the hospital resource, and not optimal use of the patient's time and their resource, having had taken half a day off work or a day off work to come to the appointment and sit in my clinic room and tell me they feel fine, only to need me 4 or 6 weeks later, at which point it's really difficult to create new capacity at short notice in any clinical service. And so if we had a better way of understanding how people's arthritis is now and will be, and this is where the AI prediction stuff comes in, if you can have an idea about how someone will be in 4, 6, 8 or 12 weeks time, it means that you could then start optimally booking people in, thinking, I will probably more likely need to see you in about 6, 8, 12 weeks time. And for those individuals who you can see have been fine for the last, year and a half and have no problems at all, who have an appointment coming up in 3 weeks' time, you could then potentially contact them with an administrator and check that they're happy to have their appointment pushed back. And by and large, if you're feeling well, you have no problems with your medication, you don't necessarily really want to come and spend your day in a hospital, and would rather get on with your life doing whatever you need to do and save that appointment for when it's needed. And so you then free up that appointment slot for the person who needs it at short notice. And so by doing that, you can improve the quality of the service, optimize the resource that you have, and make better use of everyone's time. So that's why it's important for people with inflammatory arthritis. And I'd argue for many long-term conditions, the same argument fits in with that. Inflammatory arthritis conditions are uniquely well suited to this. It's not obviously the only one, but it's particularly well suited because people know when their arthritis is in flare because it hurts, it's uncomfortable, and they really can tell you. So it's not maybe like renal disease where you might have a silent deterioration of someone's renal function and they wouldn't necessarily be aware of it. People know when their arthritis is in flare. You could say the same for people who have inflammatory bowel disease or other
Yeah.
similar conditions like that, or maybe asthma
Alive.
and
Yeah.
respiratory diseases.
Yeah.
So those sorts of conditions work really well with this sort of model of care, and certainly could improve quality and efficiency.
And is it being deployed for those conditions? And if not, why not?
So the company I work with, they have developed other long-term condition versions of what we've done in rheumatoid arthritis that have worked really well. They've got a very significant success in long COVID. So looking at managing people's long COVID and actually harnessing self-management. And that is another area that I think we haven't really touched on is actually trying to empower people to understand their condition more, which they can do if they have more data about what their condition's like, and to work on actually that sort of independence and managing initial aspects of a flare that can often be done for individuals at home without having to go to hospital to get that advice. So that sort of long-term condition self-management piece is certainly replicated in the long COVID platform that they've got. And they're also working on other conditions. They've worked on one for a long time, which is actually bladder health and remote physiotherapy. So getting people to really self-manage their bladder health, and that's called Squeezy, that one that's been very successful and used by a lot of physiotherapists across the
Yeah.
country.
Wow. That and the States, is it being used internationally?
It's not at the moment. It's mainly being used in the UK. It's predominantly down to different device regulations and legal stuff and data protection, as you can imagine. They are different in different countries. And obviously in Europe and the UK, there's slight divergence of regulation on that in that regard. And actually, even within the EU, there's differences between countries in terms of data protection. So I'm actively involved in the European Digital Research Network and digital rheumatology network. And it's really interesting speaking to colleagues across Europe who have different experiences of their local, regional legal stuff that means they can and can't do some things in Holland that they could do in Germany that they are struggling to do in France, and so on and so forth.
Yeah, fascinating. So, Phil, you see patients with a wide range of conditions, including rheumatoid, fibromyalgia, rarer diseases like lupus, as well as patients who haven't yet had a diagnosis but have unmanaged symptoms, including joint muscle pain and fatigue. We hear a lot about these sort of chronic fatigue syndromes. And I know that you're an advocate for a holistic approach in rheumatology. How does that approach differ across these sort of conditions? And what key elements of holistic care should patients and clinicians prioritize? I mean, medicine has a long history of humbling us. When we thought something was a piece of nonsense and it turned out to be, oh, well, actually very real.
Yeah, so I mean, I see people with lots of inflammatory arthritis conditions and also people with fibromyalgia. And fibromyalgia is a condition that can be coexistent with other long-term conditions, or it can be there on its own as well. And fibromyalgia is characterized by general joint and muscle aches and pains and stiffness, and often fatigue can be a problem alongside it. There can be other symptoms such as headaches and bowel symptoms. And people with these conditions often have a really difficult time trying to get a diagnosis, to understand what's wrong with them, and it can be intensely frustrating going through processes and seeing different specialists and being told, nothing's wrong, all your bloods are fine, all your scans are fine, you're discharged, and really not necessarily having a satisfactory answer to their query. And I think it often speaks to maybe part of how we're trained as doctors is to look for those problems, and those problems within, say, for example, laboratory abnormalities, scan abnormalities that we can fix or solve with a tablet or things like that. And what often is the problem in fibromyalgia is an overlay of many different things that have happened over many different months or years in someone's past that give them the symptoms that they experience that are real, that are absolutely true, and can be really very disabling, but are not necessarily associated with a life-limiting pathology that can be identified on a scan, for example. And we're not very good, I think, often as doctors, as explain to people that it's not that we don't think that their symptoms are real, it's just that maybe the symptoms they experience are not associated with that life-limiting pathology that maybe it feels like that they're experiencing. And certainly in conditions like fibromyalgia, there's a huge interplay between what we experience and how our brains work and how we interact with the world. And I often say to people, bizarrely as humans, we've designed a world that doesn't really often serve us particularly well. We've designed it around working harder and harder and more, and around screens, which are very useful in terms of technology and driving things in the future, but can sometimes be not very helpful when you're trying to wind down and get your brain into a state that it's able to start processing its information for the day. We live in an environment where there's a lot of deprivation, there's challenges in employment, people have insecure employment, they can cause stresses. And so a lot of stresses that our bodies are not really designed to deal with. Our bodies are designed to deal with running away from your woolly mammoth and your saber-toothed tiger, and they're not particularly good for dealing with a 0 hours contract when you don't know how much money is going to be coming into your bank account next week and whether or not you're going to be able to put the heating on or feed your family. Those are very different stresses. We're not very good at, our brains are not very good at processing those different stresses, and over a chronic period of time can interfere with how our bodies process pain experiences. So chronic sleep disturbance is a really big problem in people with fibromyalgia, and is often one of the root causes of it, because if we disturb that deep sleep, that deep restorative REM sleep, that's when the pain processing aspect of things can become muddled. And so the pain, what your brain is telling you is painful. And I often say to people, the pain you're experiencing with fibromyalgia is real. It's not made up. You're not just trying to make it up to sit here in the clinic and tell me about it because I know that you'd rather not be here. But I often say to people, if you break your leg, that hurts. But if you were going to chop off your head, your leg doesn't hurt anymore. So all pain is moderated in our brains. And so I think when we look at holistic care for people, and this is where self-management comes in as a really important piece here, even by explaining to people why they're experiencing the pain they're having, and almost a reassurance that it's not associated with a life-limiting illness, that it is and maybe can be very debilitating for people, but it's not life-limiting. You can then start to unpick some of the aspects of where the problems might be coming from. Where in the life is the stress is coming from? Is it previous trauma? Is it ongoing? Is it other diseases that are influencing these aspects of pain experiences that people have? And by unpicking it, people can start to understand it, and they can start building a management plan of ways that they could work on improving day-to-day life experiences in small but hopefully measurable ways that don't necessarily involve medication or injections or treatments and so on. and explain to people it is a bit like running a marathon. You have to really train for this. It's taken years to develop to this point. It's sadly not going to be fixed overnight, but with a plan, you can get in charge of fibromyalgia rather than fibromyalgia being in charge of you.
Interesting. It makes perfect sense. We hear a lot today, don't we, about sympathetic and parasympathetic tone, and all the different ways of trying to address it and the stresses of modern life. And I think that was very eloquently put. Unfortunately, we're running out of time, Phil. So I always have one final question: that if you were to stumble across a magical genie that granted you 3 wishes in your area of healthcare, what would your wishes be?
Well, I think I would, focusing on what we've spoken about today, I think it would be a way of an efficient and effective way for people to really communicate their experiences of arthritis to us, so we could really improve that efficiency on our service, so that we could give high quality targeted care to people when they need it. I think the other thing I would really like to see is, I think, better resources for people with long-term conditions, particularly like fibromyalgia. I think they often get left not knowing where to turn or what to do, and told it's fine. So some online stuff. I'm working on stuff, so I am working on something in that area with a website which we'll be launching hopefully soon, called Fibro Toolkit. And I think that if we could really work on that, that would be really helpful, because I think people could just really understand that in more depth. And then the final thing I think would have to be, generally, if we could allow doctors and healthcare professionals the time to reflect and think, and also not be so frantic in work life, that we could come up with the next big things, because I think that's something at the moment everyone in the workforce is really working hard, and you need that time to reflect on things, to be able to identify where the next big thing is. And I think, having done research and you have the luxury of some time and space to think, is when you come up with ideas. And if you're permanently up against it on a deadline, it's really tricky to do that. So I think those would be my 3 big things.
Well, hopefully they've been heard by the universe, and your wishes will be granted. Sadly, that's all we've got time for today. I'd like to thank you, Dr. Philip Hamann, for being with us today. Real pleasure chatting and learning from you, and wishing you all success with your app going forwards. And we'll put links and things into the show notes, so that would be amazing. Thanks for being here, Phil.
Thank you for having me.
And folks, please subscribe so you never miss an episode, and check out the archives. There's loads of good stuff in there, and join us next week for another fascinating episode. Until then, I'm Dr. Jonathan Sackier, proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.